To this video. I'm Jedynak. You're about to discover the single most important assessment and treatment technique that you can do for ankle and lateral leg problems. It's probably something that you didn't get taught in your university training. I'm going to put an end to that right now. This lesson, I'm going to teach you the mobilization technique of the distal fibula. Now, this is a crucial joint and crucial technique that we need to really get on top of, because ankle injuries, these are, just think, how many patients have you had that have ever had an ankle injury of some sort in their lifetime? Heaps, right? And 92% of all ankle injuries have a problem or affect the ATFL. And this is one of the key ligaments within the ankle structure that has great impact on the talus and the stability of the talus, and it also has a major impact on the fibula-talar team, because these two guys work together and they make a great team unless they've been damaged or compromised. We also remember speaking with a good friend and the podiatric nemesis, Bartold, and he said, if I could only treat one joint, it would be the ankle. And that's because of not only the effect that it has locally, but because of the impact that the ankle plays on the entire kinetic chain. So ankle, real important. We're going to also highlight that one of the key factors that we need to be aware of around the ankle and subtalar joint is it has the greatest concentration of mechanoreceptors in the entire lower limb. So what this means is that if there's a damage, compromise, or incorrect input from the mechanoreceptors up to the brain, then this can affect the instructions from the brain down to the muscles, causing things like muscle guarding. We might get sensitization, where people become much more sensitive to very little provocation, and the normalization of the neuro input and pathways is a critical part of what we're going to be showing you today. So here it comes, lateral mobilization of the distal fibula. One of the key factors we need to take, or let's just go, distal fibula. So this is what we're going to be working on. Now, in order to determine whether you are actually going to be, should you do this to your patient, you've got to take into account the clinical clues. Now, what are the clinical clues for the ankle problems that we see? If your patient has a history of ankle sprain, like that's clinical clue number one, you definitely want to be doing this technique for. If your patient reports weak ankles, now I know that term is not diagnostically accurate, but that's the kind of the words that your patient will be using. If they describe a history of, I constantly go over my ankle, or my ankle always had weak ankles, that will be an important indicator for doing this lateral distal fibula mobilization assessment and test. The same technique you can use as an assessment and you can use it as a test. And I'm going to show you exactly how that works today. If your patient demonstrates any sign of ligamentous laxity, so when you do the anterior the ankle draw test, and the foot moves, or literally the ankle moves within the ankle mortise, now there'll be some movement, and it might be 3 or 4 millimeters, which is considered normal. But if you're getting 7, 8, 9, 10 millimeters of movement of the foot from the ankle within the ankle mortise, we are going to have some important rehabilitation and stabilization mechanisms that are needed. The assessment of those patients, though, distal fibula mobilization is a key part with that. The other elements that we need to take into account are the clinical tests. So the clinical tests will help you in your clinical reasoning and decision making about how you're going to take care of this patient. So the first clinical test, when we look closely at the fibula has a range of movement, and it kind of swings like a pendulum. The fibula is not anchored either distally or proximally, so it needs to be able to move within its normal range. And one of the key factors is with dorsiflexion, we need to actually get some translation of the fibula laterally to enable the wider part of the talar dome to slide back into the ankle mortise. So in the sagittal plane, an important clinical test is to check the range of motion. And that range of motion in that pendulum arc in the sagittal plane will typically be, in a normal adult, is around 4 to 5 millimeters. That's 4 to 5, not 45 millimeters, because if you've got 45 millimeters of movement there, you're probably going to need some surgical correction rather than manual mobilization. So 4 to 5 millimeters is normal. And sometimes that surprises practitioners that it can actually move that much. It needs to. That's certainly part of a normal ankle fibula range of motion. Another important clinical test is just checking your patient's balance and proprioceptive ability. Now, if they're able to balance on one leg and maintain that while talking to you on Facebook Live, that's a pretty impressive achievement. Normally, if you want to challenge them to some degree, so maybe it involves getting them to look from one corner to the next corner and see how they can go. Oh yeah, okay. Is that an earthquake? All right, so these, you want to make an assessment of their balance and proprioceptive capabilities. And the most important, these are all important, but probably one of the other crucial important tests that you want to definitely include here is, it's a special note, the lunge test, also known as the knee to wall test. Now, the lunge test is an important test. It should be a standard part of your biomechanical evaluation. But the importance of the lunge test is the fact that your patients can cheat. Not deliberately, not intentionally, but in an attempt to get their knee to the wall. There are 6, okay, that's 5 plus 1 here, 6, even 7 ways that your patients can cheat with the lunge test. And you need to factor that in to ensure that you are comparing your intervention reliably. So comparing apples with apples, because otherwise you may get inaccurate results, which affects your decision making and ultimately affects the treatment you implement for your patient. So make sure you really get handled, be accurate, be disciplined, be a master of the lunge test. Okay, so that's pretty much the mobilization that we're going to be doing. Why you need to do this, we've covered the important factor of the ankle, and before you do any actual mobilization treatment, you need to go through your clinical clues, clinical tests. And this is the sort of thing that we go through in detail in our foot mobilization therapies training. But I want to teach you this technique today because I know your very next ankle patient, you can do this. You can literally do this assessment and treatment mobilization for your next ankle patient. It's not difficult to do, but you need to know some of the key points and the key elements to make sure that you get the accurate feedback from your patient. Now, I'm going to cover some TEDS tips with you here, and that is, if your patient has a history of ankle injury, and if it's been a substantial grade 2 or grade 3 type of inversion sprain, it's likely that their ATFL, anterior tibiofibular ligament attachment site on the fibula, is going to be hypersensitive. So literally, if you place your fingers onto the most anterior portion of the fibula and you get your patient wincing at that, even though they might not have injured their ankle, it might have been 6 months, 6 years, or even longer before then, that sign of sensitivity or tender points or trigger points tells us that there's probably a compromise in the ability for the ATFL and how it works. So that's another clinical clue you want to make sure that you're on top of, because if they're wincing here, you've got to have to manage that and address that accordingly. Okay, the other thing that is worth noting is the anterior position or the anterior tendency of the fibula post-ankle injury. So what I mean by that, if there's a history of ankle sprains, ankle injury, there's a compromise of the integrity of the ATFL, it means that the talus itself can have the possibility of shifting anteriorly or being more prone to be positioned anteriorly. And it means, literally, because of the team of the talus and the fibula, it can drag the fibula forward as well. So when you do the range of motion testing, normal, as it moves, it should be symmetrical, meaning equal distance anterior and posterior from the resting position. Post-ankle injury, if you notice that it goes anterior, twice or 3 times as far as posterior, that's a clue that we need to do some mobilization from a therapeutic and intervention perspective. So we would then apply the mobilization that goes like this. So first thing, patient position. All right, so we've got Scully here who's cooperating reasonably well right now. It's just having a little bit of an afternoon nap. And with this position, if you have your patient, today I'm going to show you this technique with the patient in a supine position. So whether they're lying flat down or in a seated position, that's fine. You can do the test exactly the same in a prone position. But given that most practitioners will be in a seated or supine position, their patients rather will be in that position, let's show you how to do that. First thing is, we've got the patient in the supine position. With any mobilization technique, what you need to do is you need to isolate the joint or the bone that we're going to mobilize, and you need to stabilize the surrounding joints. And because we have so many joints in the foot, there's lots of bones that potentially could contribute. It's almost like accessory movements that can take place. And there will be to a degree, but what we're going to do is we're going to isolate the distal fibula. The way we're going to do that is with your medial hand, just rest it on the tibia and rest it on the medial border of the foot. Now, if I just show you the other side, so stabilize, rest your medial hand literally right across the medial ankle. Thumb and index finger are going to be on the tibia, and the rest of the foot will be sitting within your hand. Then we can tackle the fibula. So that's what we're going to do on the medial side. Posteriorly, it's a typical position where I will put the patient with the knee flexed so that I can use the table as, the table as a brace for the calcaneus. Now, the other option is we can have the leg literally with the knee fully extended, and we can work it this way. What I find is that when the knee is flexed, I'm just in a more comfortable position and I have less interference. Like my hand is not going to hit into the table. So that's just a side benefit here. Technically, it makes no difference. What you do need to be mindful of is with the knee flexed, the leg is not as stable. So what that means is that if the leg rotates in or out, or if you get the patient helping you or trying to get some movement when you want stability, then straighten the leg out, or give them the instruction, just hold your knee still. So I've stabilized the medial side. I'm going to place my thumb on the anterior portion of the fibula, and then I'm going to place my index finger on the posterior aspect. And you're looking for the most prominent anterior and posterior points, meaning the widest point of the fibula base. So I've got my thumb and I've got my index finger. Now, depending on the size of the foot and ankle that you're working on, depending on the size of your hands, you can use 2 fingers as well. So it's quite common for me in particular when I'm working on fibulas is to have my thumb in position, and then I'll have my 2 fingers going right on the posterior aspect as well. But I keep my fingers together because if I do this, I could get arrested. So we place our thumb, place our finger. Once it's stabilized the medial side, in position on the lateral side, if you only remember one thing, it's these 2 words. 2 words, that 2 things, one thing, and that is position and precision. So what that means is your position of your contact points needs to be spot on. If you are too proximal, too distal, you won't have firm control of the fibula. So you need to have firm control so you consistently check before and after your intervention as to any changes, what level of changes have taken place. And then the precision is the action. So I mentioned earlier about the pendulum style of action. We got thumb, we got index finger and middle finger. I'm in position here, and now I'm going to literally swing the fibula in that pendulum action with keeping in the sagittal plane. So when I do that, now obviously these wires and staples here aren't going to allow too much movement, which actually there are some patients walking around who've had an ankle fixation with wires, so you won't get any joy or any luck trying to mobilize them. But once I'm here, the action is to push 2, 3, back 2, 3. Push 2, 3, pull 2, 3. And what I encourage you to do is say those words in your mind. Because sometimes when practitioners first start doing mobilization, they think either harder or faster is going to get a better result. Now, that can get a better result if you're a adolescent teenager. However, when we're mobilizing here in a very caring, conscientious, conservative way, we need to push 2, 3, pull 2, 3. And you'll do this action 3 repetitions. Nah, it's not so poetic, but I'm sounding pathetic. All right, so normally you'll do 3 repetitions, and in a typical healthy ankle, 3 repetitions, you'll start to notice increased movement. See, when you first start mobilizing, there will be a level of protection. It may not necessarily be muscle guarding unless it's a recent ankle injury and the body is still in recovery mode. But if you've got someone who's got their weak ankles, what you'll find is that you'll meet initial resistance, and then the capsule and the ligamentous tissues gradually start to release. So think of things in the multiples of 3. So we'll do 3 repetitions. So it's push 2, 3, pull 2, 3. So that's the speed. And then the force you'll apply is around, in a typical adult, 3 to 5 kilograms of force. Now, if you've got a big rugby player with, that's built like a fridge, you may need to ramp that up to, 5, 6, or 7 kilograms of force. If you've got an aged granny, then she might only need 2 to 3 kilograms of force. What's important, and this will be another TEDS tip, is work within your patient's tolerance. If you have a look up there, it doesn't say TEDS tip, but you're going to write it in your imagination. That would definitely be worth there. Work within tolerance. If they have sensitivity on this anterior portion, and you've got bony thumbs like me, you can really cause some grief and give them a bit of heartache and a bit of ankle ache with that. So don't do that. What I would do in that situation, first step, is I would pad out my thumb. So instead of using the tip of my thumb, I would just flatten it out so I've got more flesh rather than the distal bone in the phalanx of my thumb pressing on there. That, however, can sometimes be too sensitive and still not tolerable. So then what I would do is use the base of my thumb, this fleshy part right here, and I'd put that over the anterior portion, grab hold of the posterior portion, and then using my hand and do the push 2, 3, pull 2, 3. If I had one of those rugby players, sometimes I need to get my thumb into position and then use my opposite thumb and really generate more force by loading that anterior portion. Then I have to do all the work with pulling the fibula back towards me. So there are just a couple of extra TEDS tips here on how to get that mobilization effect. So just repeating, it's 3 repetitions. If you notice that there's not any improvement or change in the range of motion there, then what you need to do is repeat another 3 times. So it'll be 6 repetitions in total. And that's typically the amount of mobilization that would start opening up and releasing those connective tissue restrictions. The other important thing when you're doing the mobilization as an assessment tool is you need to feel for the qualities in the joint, in particular the end range qualities. Now, the reason for that is depending on the structure, the anatomical or physiological structure that is influencing that end range position, and if it's limiting the joint, this will affect your treatment decisions. So how you're going to treat an end range that's controlled by a ligament, or that is limited by a tendon, or limited by a muscle, or limited by bone, or limited by fluid, your treatment decisions will be different for all of those criteria. So part of your assessment with this mobilization, first thing is you do the mobilization as an assessment, and then I'm closing my eyes because now, yes, I'm closing my eyes and adjusting my glasses so I can hear more effectively, but I can feel more accurately what's going on in the joint. If I take out my eyes and remove my visual input, it just means that there's going to be more tactile or sensation going into my brain. I have limited brain matter, so I need to maximize the most of everything that I've got here. Okay, you're right there, Scully. So I would close my eyes and then go through that mobilization. Now, in a normal, healthy fibula mobilization, the end quality will generally be ligamentous or capsular, and the quality that feels of, it feels like leather. You imagine a leather belt. Oh, it's staying there all on its own. Magic. That leather quality, so it's very firm at the end, and what happens is there is just that hint of give right at the end. If there was a hard, stuck, bone-on-bone end, it's pretty unusual for that to happen with the distal fibula. Can certainly, it's a bit like the ankle. If you were to dorsiflex, and you would get that end bone-on-bone feeling, particularly if the ankle, the talus is anterior and you do that motion. That quality is unlikely to be experienced here. That would definitely give you some warning bells that something's not right. If the fibula is hitting bone somewhere, it may be in the anterior section hitting the tibia here. That's a possibility there, but you'll generally get that soft end feel, the leathery feel happening first. The other important element with this mobilization test is to compare with the opposite side. So if this is the uninjured side and this is the injured side or the problematic side, the quality that you feel, it may be leathery on both sides, but if the compromised or the injured side has a lesser range of motion, even after that 3 or 6 repetitions, compared to the non-injured side, that gives you another clue. That may tell you that then the ligamentous and capsular tissues have, maybe they've gotten adhesions or restrictions within the tissues that doesn't allow that full range of movement. Another quality is soft, almost bouncy type of end range quality. This is not uncommon, particularly with if there's edema. Now, recent ankle injuries and there's still a lot of swelling, you'll have that soft feel. That's probably more getting your fingers and hands onto the fibula rather than the end range position. Or then you have those patients who have lymphedema, and so where a lot of that swelling takes place, it feels very fluid and spongy. So in that case, obviously you would need to, your focus of treatment may be on to reduce that edematous buildup, if that's the priority in your clinical evaluation. And so I reckon that's pretty much what the classic, what if there is scar tissue in the ligaments or capsules of the ATFL? You may feel crepitus, it may feel irregular, it may feel a little bit rough and gritty. Sometimes crepitus is probably more typical of joint surface damage. And if you've got articular surfaces compromised, then that's, you'll feel that sensation of crepitus there. So you can see how there's a number of different treatment options that you will then need to take into account once you've evaluated or determined what is that end range quality. So yes, it's a simple mobilization technique, but there's a number of moving parts and a number of things that you need to consider as a practitioner in order to work out your clinical reasoning to determine what's going to be the best treatment option, treatment intervention that you apply. It reminds me of good friend and FMT Ninja Master, Mark Hewen. He's based in Manchester in the UK. And Mark, high five. Sorry, I was a little bit of a random input there. Mark, we first met, I think it must have been 2012 in London. He came down, did his first foot mobilisation therapy training, and then joined us here in Adelaide, so the other side of the world, in 2015, 2016, to do some of the advanced training. And he is now absolute FMT Ninja Master legend, working with the elite sports players. They call them footballers, but we call them soccer players. He's asked, I'm not sure if I'm allowed to mention the name. If I did, we may not be united in everything that we proceed with. But he is based in Manchester, and when we were there with Mark in Manchester, we were united at that time too. Hopefully a transcript of that won't upset the legal department. All right, if mobilization manual therapies is something that you're interested in, if you're not doing it or not using it in your clinical practice for your MSK patients, I would have to ask you, why not? Because it is the single most important element that MSK practitioners can do, particularly if you're using orthotic therapy. It's like the icing on the cake. It's what can make a real difference for those orthotic patients who kind of get better but not best. It's really a useful modality. It certainly transformed my clinical practice from 1994 when I was exposed to foot mobilisation therapies. We have our mobilisation workshops coming up in Sydney, Melbourne and Brisbane this year. If you want to add this skill, have a new treatment option in your toolkit. If I could leave you with one expression, it would be do something new in 2019. You've got to keep at the leading edge of your therapy services, particularly for those patients who are active and needing and benefiting from orthotic therapy. FMT is a great treatment option to enhance as well. If you have already done FMT training with me and would you know the benefits of it, we've got really looking forward to our advanced FMT level 2 and 3 training happening in beautiful Byron Bay at the end of August this year. We will have the links on this post to give you all the details of what's included, what's happening, what the fee options are. We have our early bird special offer ending this Sunday. No, not this Sunday. Sunday, March 31st. Okay, 2 Sundays. So it's about 10 more sleeps. You've got time to get yourself organised. Highly practical. I am Mr. Practical. So looking forward to making sure that we enhance your clinical skills and abilities straight away. Today, your very next ankle patient, do the lateral fibula mobilisation. I know it's going to help you with your assessment and treatment. Any questions, any comments, type them in the box down below. We'll make sure we get responses to you to ensure that you too can help more people through manual therapies. I think that's it for me for now. I thank you for your attendance and your attention. Until next time. And you know what's happening next time? Next time we are going to do the proximal head of the fibula. Yes, so then we'll have the whole fibula taken care of, and your whole lateral leg patients and knee patients will get some great benefit there. So, Scully, he's just going to take things lying down for now. Unfortunately, he doesn't have the heart to be able to contribute anything vocally. But until next time, serve with spirit, consult with care, and help more fibulas today.